breast cancer screening in Canada, and I'll give you some context internationally, to recognize the benefit of a multi-factorial risk prediction for population stratification of risk, and to discuss some of the challenges and potential barriers to implementation. So I don't need to show this slide to you guys. This is something that you all know, but I still think it's useful because we sort of hang our hat on this 1 in 8 women are expected to develop breast cancer in their lifetime. But of course, we know that risk is not uniform across the population. Still, current breast screening guidelines are largely based on age. Most, and this is definitely in flux, recommend screening every 2 years for women who are ages 50 to 74 years. And of course, in Ontario, we're in the process of expanding that screening to include women in their 40s. And in other provinces, for example, in Alberta, they start at age 45. So this is quite variable. Now, this age-based screening overlooks the fact that there is heterogeneity in risk. And really what this means is that we are, as Ellen said, likely over-screening some people and under-screening others. So this is a snapshot of what we currently do in Ontario in the OBSP. We have the population-based program, which really captures sort of 99% of the population is at this sort of, is included in this sort of category, this broad population risk category. And here we screen, as I mentioned, this is changing, but we have this age-based eligibility where screening starts at age 50 and ends at 74 with some room for referrals both before and after that. Now, these individuals get mammograms every 2 years, and we do have this other caveat where we have this still based on those that are age 50 to 74, but you can get annual screening with mammogram based on family history and having extremely dense breasts. Now, on the other side of this, we have the high-risk program, which started more recently. And this really is it's less than 1% of the population that tends to fall into this category currently. And to be eligible, individuals need to meet one of 4 high-risk criteria. And these are the things you would think about, right? Being a BRCA mutation carrier. But there is also this category here where we have individuals who have a family history and an estimated lifetime risk greater than or equal to 25%. And these individuals, have annual mammograms along with an MRI, and usually they're about 2 months apart. So we do quite well at getting these imaging modalities to be paired. And so really the OBSP has both age-based and some risk-based screening already implemented and functioning very well. And this is actually a real benefit when we look towards expanding this type of approach more broadly to the population. And this is exactly the infrastructure that we built the PERSPECTIVE study on. So modeling evidence suggests that a risk-based approach could optimize the cost-benefit ratio as well as the cost effectiveness. And now there are some caveats with that I'll go into a little bit later. And there is really broad international interest in this type of work with studies in the United States, Europe, and the UK. And in Canada, as I mentioned, we have the PERSPECTIVE I&I study, where the I&I stands for integration and implementation. So that was really the focus of this project. Now, that being said, many women receive an approximate risk estimate based on their family history just by their family doctor. There are, the questions that are asked routinely within the family doctor setting are what sort of trigger the types of referrals to clinics for more formal risk assessment. And there are risk prediction tools that are currently used within the genetic clinics in Ontario to assess breast cancer risk or risk of carrying a mutation. And so this can either, based on the risk estimates, can then send someone so they undergo multi-gene panel testing, or they can be directly referred into the high-risk program. I just wanted to go a little bit just to make sure that everybody's on the same page with what we mean by risk-stratified screening and multifactorial risk-stratified screening. So when we talk about the multi-gene panel testing, which is the standard genetic testing that is typically done in individuals, it's frequently done in women who already have breast cancer. This includes the collection of genes of high and intermediate penetrance variants that are associated with relatively high risks. So the genes that we're sort of used to hearing about, BRCA1 and 2, PALB2, CHEK2, and so on. We also have these other collection of variants that are down here. So these are variants that occur more frequently in the population, but are associated individually with very small risks. So when you look at them alone, they're not associated with a particularly high risk. But when we combine them into what's called a polygenic risk score, together, they can confer quite a high risk. Now, the polygenic risk score of record is one that was published in 2019 in the American Journal of Human Genetics. And this was work that was largely done by the Breast Cancer Association Consortium. And this polygenic risk score has been incorporated into the most recent versions of Bodicea. Bodicea being a risk prediction tool that is currently implemented within the program, within the OBSP. So what Bodicea does is it takes genetic information on the rare and intermediate penetrance variants, information on the polygenic risk score, detailed family history, lifestyle and hormonal reproductive risk factors, and so on, and estimates risk. So what do we mean by population stratification? Okay, so when I talked about it at the beginning in the context of the high risk OBSP, we're really identifying those individuals who are at the highest risk. But of course, there's a distribution of risk across the population. Now, this comes from a paper that uses NICE guidelines from the UK. So their cut point is a lifetime risk greater than or equal to 30% for high risk, but you can get the picture here. So here we have the distribution of risk if we just look at the risk factors. So these are things like reproductive factors and lifestyle factors, things like that. And here is our 13%-ish risk of breast cancer. That's our average population risk. And you can see that there is a distribution of risk here where there are still people who are falling into this moderate risk category. Now, if you look at the PRS, so you just take those common variants and combined into a polygenic risk score, you get a wider curve. So we're already getting better stratification just by looking at the polygenic risk score. So here now we have a greater proportion of individuals who are falling into this moderate risk. We're getting a wider curve. Now, when you combine everything together, that curve gets even wider, right? And we're able to further stratify the population. In fact, about 15% fall into that higher than average or what they call moderate risk, and about 1.2% fall into that high risk category. Now, just because I know there are likely genetic counselors in the room, I have included one slide to show that the polygenic risk score can also help with risk stratification for carriers of variants in CHEK2, for example. And CHEK2 is a particularly hard, that's a hard one to counsel patients on. But when you where you use the green curve is risk factors only, the blue risk factors and mammographic density, the yellow curve PRS, and then everything combined, each curve getting progressively wider. We actually have, this is an example of someone who's, this is risk at from age 20. We're looking at 35% are at population risk, 44 in that elevated or moderate risk, and 20% into that high risk. And so this is, a really informative, this is really helpful when you have these variants that are considered to be of intermediate penetrance, but really that penetrance is really quite variable. Okay, so that's what we mean by risk stratification. And when we're talking about doing this more broadly for fully risk stratified approach to screening, we're talking about taking that risk prediction and risk estimation out of the genetic clinic and moving it into another setting to assess the population more broadly. So the overall goal of the PERSPECTIVE study was really multifold. It included a bunch of different activities, some including more sequencing to identify novel variants. This is where CanRisk was developed. So the tool the user interface web tool that implements Boadicea in a more user-friendly way within the clinic. But I'm going to be talking mostly about this activity 3, which is this pre-implementation type study where we're looking at actually how we could operationalize within the existing screening programs. Okay, so the overall goal of this activity was to develop the framework to support the implementation and try to find to really understand what was needed in terms of resources, both human and otherwise, and the acceptability of uptake, how individuals felt about learning about their risk and how they responded to learning that risk. So I'm going to be focusing on discussing the results from these first 2 objectives, sort of sub-objectives of this aim, where we talk about issues related to recruitment and risk assessment, and then as well as acceptability of a risk-based approach to screening. Okay, so as I mentioned, we started recruiting individuals right before the pandemic started. We recruited individuals to undergo multi-factorial risk assessment and to actually receive that risk level, have that risk level communicated to them along with a screening action plan. And then we followed them up over time. These were people aged 40 to 69 who had a previous mammogram in Ontario or Quebec. We had the requirement that they had to have a previous mammogram because that is an element that goes into Boadicea for estimating the risk. We excluded those who had a prior personal history of breast, ovarian, or pancreatic cancer. They were known to be at high risk, or they had a history of genetic testing or counseling for breast cancer. So we were trying to move away from those we already knew to be high risk and focusing on those individuals who were in the population average risk screening programs of both provinces. So we did extensive data collection for this. There were 3 questionnaires over time. The first questionnaire really collected everything that we needed for risk assessment. So everything that would go into Boadicea, but it also assessed some sort of baseline ideas about risk stratified screening, about mammography screening in general, about sort of anxiety about breast cancer, how much they thought about it. Along with that, at that same time, we collected the mammogram reports so we could get information on density. And each individual was sent a saliva kit so that we could get DNA to calculate the polygenic risk score. At the time of risk communication, we also sent a first follow-up questionnaire that assessed sort of how receiving that risk information felt to them and whether they were going to change behaviors. And then again, we had a first 1-year follow-up questionnaire that was completed just at the end of the summer of 2023. So to do this, we created a new clinical grade test that included just shy of 300 of the SNPs that go into that polygenic risk score that of record, that one that I showed you the publication for from 2019. And so this was done, the DNA extraction and the genetic test was developed and conducted within a CLIA certified lab. We needed to be able to communicate this information to the individuals who are taking part in the study. And we really wanted to create a resource that could be easily taken up by other labs moving forward. Now, when you look at the polygenic risk score, you basically take a score and it's normalized. So you're going to normalize it based on the standard deviation, the distribution of the polygenic risk score. And once you've done that, anybody sort of who falls at this population mean, that's sort of your average risk. If you've got a PRS higher than that, then it's higher risk. And if it's lower than that, then it's lower risk. I mean, it's more complicated than that, but to understand what the general principle, that's all you really need to know. So we collected all that information through the questionnaire, the mammogram report, and the polygenic risk score. We put all of that into CanRisk, and then women are categorized as either being at general population risk, moderate risk, or high risk. So this is a look at the CanRisk tool, which I just mentioned is the web tool that's now used to implement Boadicea within the clinic. And it's been made much more user-friendly with the use of this particular tool. It's much easier to implement. And it's really quite flexible in the outputs that you can get from it. We used, it has many more outputs than just this, but we focused on the 10-year risk. And so that's what we estimated and communicated. So once we had estimated risk, we put this information into a letter that was double branded, and it comes from Ontario Health Cancer Care Ontario. So, it looks like the usual letter that you get from Cancer Care Ontario saying that it's time for you to have your mammogram. And it basically communicated a risk level of either average, higher than average, or high. It put that risk into context in terms of how it compares to other Canadian individuals, their age, and sort of tried to tell them what their likelihood of getting cancer was over the next 10 years. Now, with this letter came a booklet that is meant to help understand, just to support that information and help them understand what that estimate means. So it included information on how we estimated the risk, what you can do to reduce your risk, and then what sort of steps you can take moving forward based on that risk. This is sort of the overall flow of how things looked. So we had our population from Ontario and Quebec who had to have had a prior mammogram, ages 40 to 69. We collected all of this information and estimated their risk using Boadicea. They then fell into one of 3 risk levels based on their age. So we used age-specific risk thresholds. They then received their letter for risk communication along with the booklet to understand that risk. And depending on their risk level, there were some other sort of instructions that were provided. So if individuals were found to be high risk, they were offered genetic counseling. Actually, anybody could receive genetic counseling if they asked for it, but they were offered it actively if they were found to be at high risk, in all instances, it was recommended that they communicate this information to their healthcare provider if they felt they wanted to. Now, there were some differences here in Ontario and Quebec. So in Ontario, we just said, here's your information. You can tell who you want about this. So you can tell your healthcare provider that might be a good idea. In Quebec, it was required that individuals have a primary care provider on record, and the risk letter was sent to both the individual and to her healthcare provider. So already you're seeing issues related to different contexts within different healthcare systems within Canada. Okay, so then based on that level, they were also communicated a screening action plan, and this sort of followed the current screening program recommendations, right? Because we had to implement this within the existing screening program. So to do this, those that fell into the high risk category were recommended to have mammogram and MRI or ultrasound every year. For those ages 40 to 69, for those aged 40 to 69 in the higher than average risk group, mammogram every year. And then the 50 to 69 average risk mammogram every 2-year group for that population or average risk group. Okay, so overall, when you look at the recruitment over time, we ended up with just over 3,700 individuals who had their risk calculated. Interestingly, we did have some individuals who elected to be within the study, but decided not to know their risk, which I think is interesting. And so that's something to think about what that means. But so there were sort of slight differences in the way that individuals were recruited. I already mentioned this, the requirement for the primary care provider in Quebec. In Ontario, we did this sort of largely based within the existing system within the OBSP. So invitation letters were sent through the OBSP to one of 6 sites, and we promoted in mammography centers, newsletters, and media. So there was also room for self-referral. In Quebec, this was mostly done through self-referral. So they did a big media push, posters, flyers, screening centers. There was radio interviews and television interviews and things like that that got the message out. Now, when you look overall, we ended up with just shy of 80% of the individuals who had their risk estimated falling into the average risk category, about 16% in the higher than average, and just over 4% falling into the high risk group. And one thing, I know it's a little small here, but if you look at the bottom, you can see.
Your attention, please. Cold blue.
Hold on
D
one
doubling,
second.
3rd floor, room 32, bed 1. Your attention, please. Cold blue. D doubling, 3rd floor, room 32, bed 1.
Is he going to do it again? Okay. In a bit. Okay. So if you look here in the Ontario, when this is broken down by Ontario and Quebec, you can see that the proportion of high risk individuals is much higher within Quebec. And that's because they don't have a formal high risk screening program. So we were able to really systematically make anybody who was known within the high risk program ineligible for the study, whereas that was not possible within Quebec. So that's why you can see that slight difference in the distribution. Okay, so this is what the overall timeline looks like. So at the time of risk communication, we had that first follow-up questionnaire that asked about screening behaviors and any sort of diagnoses, as well as knowledge, attitudes, and beliefs related to risk stratified screening. And then again, this information was asked at 1 year follow-up. Okay, so when you look now, can I minimize this? Because you can't see what I'm talking about.
Go into more, click on those 3 buttons and more, and then hide floating.
Oh boy. Hide floating meeting controls. There we go. Oh, that's better. Okay, thank you, Anne. Okay, so now here, if we look at this is the distribution of risk by age group. Okay, and we'll start looking overall. So in the full population, this is the numbers that I just showed you on the previous slide. You know, about 80% fall into the average risk, about 4% into the high risk group. And we can see that already this is quite variable when you stratify by age, with a higher proportion of individuals who are in their 40s falling into this higher than average or high risk group. So already right away, we're seeing that we're not doing well with just an age-based approach to screening. This is not capturing these individuals who are at elevated risk. Okay, so now let's look at this by what kind of screening individuals are getting under the current screening guidelines based on their risk level. So here is what it looks like if you have just age-based screening, right? So we had the 13% of individuals, so a small proportion fell into this, were in their 40s, and so they would not be getting screened. And we have this 50 to 69 who are eligible for screening. And in fact, this is a screening population, so they are being screened every 2 years at minimum with mammogram. Now, if you take this and you stratify by their risk category, then you see, okay, we have actually, among those who are found to be average risk, this is perfectly fine for about 67% of our individuals who are in their 40s, as well as for about 82% of those that are 50 to 69. And they are getting a mammogram every 2 years, so that's fine. But then we have all of these women over here who are actually being underscreened. So these individuals who fall into the higher than average risk would benefit from having mammogram every year, perhaps. Whereas these individuals here, to be screened appropriately, based on our current guidelines, they should be getting mammogram and MRI annually. Okay, so if you recall, we also have this provision within the population-based OBSP for annual screening for those who have a family history, but this again is starting at age 50. So here we have individuals who have this this first-degree family history. They so they would be receiving mammogram every year under the current program. Now, if we actually look at what their estimated risk is, we see that we're actually over-screening about 60% of those. They would be totally fine just having mammogram every 2 years. We were screening about 27% of them appropriately. They were getting the mammogram every year, but about 30% actually fall into that high risk category once you're looking at a multifactorial risk assessment and not just considering family history, and so should be getting mammogram and MRI every year. A similar story, but a little bit more mixed, is seen when you look at breast density. So here we have the provision within the OBSP to have annual mammograms if you have extremely dense breasts. So that is just shy of 13% of the study population here, where really about 49% could fall into the average risk category. So it could actually be sticking with the mammogram every 2 years. But about 17% actually fall into this high risk group and would again benefit from more intensive screening. So it's a real mixed bag. So this is much more mixed than what we're seeing with family history. But overall, this sort of aligns with what you see from those curves I showed you at the beginning, where you get that wider curve. You're getting better risk stratification by considering a multifactorial risk assessment. Okay, so let's look at some of the recruitment and risk assessment type issues related to this. Now, there's a lot of information here, but what this is really capturing is information about how the questionnaire was completed. So this is the baseline questionnaire capturing all of the information that was required for risk assessment. So only in Ontario did we try or offer 2 different modalities. We gave individuals the option to do it online versus on paper. And we did this because we saw that it wasn't enough really to do it just online. And that was our experience in prior studies that had just finished prior to this study. So we went along with that, and we did see that there are still individuals who are older, who are visible minorities, are less educated, and have overall worse health that preferred the paper version of the questionnaire. Now, likely as we move through and the millennials get older, moving into a fully online system will be possible, but at least right now, we're not able to do that. Now, the other issue is that there's quite a lot of information that goes into estimating this risk. If you're going to use all the elements that go into Bodicea, it's quite intensive in terms of the amount of data that needs to be collected, in particular, really related to the family history, especially when you're talking about doing this really broadly.
Your attention, please. Cancel. Code blue. D Delta Wing, 3rd floor, room 32, bed 1. Your attention, please. Cancel. Code blue. D Delta Wing, 3rd floor, room 32, bed 1.
Okay, so now we're looking at where information required verification. So this means actually phoning someone to make sure that we have the correct information on their questionnaire to estimate their risk, okay? So what we found is that individuals in Quebec required much more follow-up to capture all of their risk factor information. And a lot of this was really about large families and the burden of having to record a very detailed family history. But again, we saw these same issues with individuals who identify as visible minority and those with less than a bachelor's degree or above education. They required more prompting, more verification and double checking of information. And this is important because this is a huge resource, a huge human and time resource in order to make sure that you're getting the right information to estimate the risk. So the overall findings related to the collection of this information is that we had about 10% of consented participants withdraw. Many because they just didn't complete the question. They got part way through the questionnaire and then they were like, I'm not going to do this. Now, some of this I think can come from doing an online questionnaire. A paper questionnaire allows you to write things in the margins and to write little notes that sort of extend beyond. So if you're not sure what to put in that box, you can say why. But that's sort of something to consider. The resource, it was a very resource intensive activity in order to get all of this information. In order to follow up, about 34% required verification, mostly, again, as I said, related to family history. And about 27% still preferred providing information on paper or by phone rather than entering it online. Okay, so the second objective within this activity was to look at the acceptability of this approach. So as I mentioned, we asked questions about how individuals felt about receiving that information about their risk and if it was going to change their behaviors. So one of the things that we asked at baseline, risk communication, and at 1-year follow-up was their beliefs about the advantages of a risk stratified approach or knowing their breast cancer risk. So, the types of advantages that we asked about were things about gaining knowledge about my health, informing my family about breast cancer risk, planning for the future, changing my lifestyle, all these types of things. And they were asked to rate their likelihood of rating that as an advantage on a Likert scale. Now, there's a lot of information on this slide, but really all you really need to look at is up here. We're talking about 96, these are all over 90% of individuals who are saying that they agree that this is an advantage across the board, whether it's knowledge or easing their worry. The ones with more variability, when you actually look here, related to easing my worry, informing my family, and knowing how to plan to the future, most of that variability is based on risk, right? So learning that you're high risk is not going to ease your worry. Learning that your average risk doesn't tell you anything about how to inform your family, right? So most of this variability comes from the risk category. But overall, you can see that the vast majority of individuals perceive it as an advantage to learn and know their breast cancer risk. Of course, we also asked about potential disadvantages, and a lot of this has to do with how that information might make them feel or might make them worry, but also information about whether it was complicated information that they wouldn't really know what to do with. They really wouldn't know what to do with it. Now here, you can see that basically there's much more diverse range in individuals who perceive some of this information as being disadvantageous. We're looking here, if it's a little bit of a double negative, but you want to look in the ones on the far right of each section are those that say it's not a disadvantage. They disagree, it's not a disadvantage. And, so largely people are seeing the benefit over the potential harm. Now, the one where we did see some variability is related to getting complicated information that I don't understand. And when we dug into this a little bit more, we did see that this was related to education, and also seemed to have some variability by province, which is really interesting, where really this was a problem. This was something that was perceived as a disadvantage in Ontario. And if you recall, in Ontario, we did not communicate this information also to their primary care provider. So this could be an argument for the benefit of also communicating that information to the primary care providers to support the individual in understanding that information. So another thing that we assessed at the time of risk communication was decisional regret. Now this is a score, it's a standard score that is based on 5 items, 5 questions, and it ranges from 0 to 100, where 100 is the highest point of decisional regret, very high regret. And you'll actually see that the regret was very low across the board, whether overall, by province, and by risk level. This is very, very low. Even though we are starting to see some variability a little bit here, we're still talking about on a scale that goes to 100, we're really barely scratching the surface here. So overall, for the individuals who had their risk estimated and communicated to them, they did see a balance, I think, between the benefits and the potential harms. They overall saw that that this was something that they could get behind. But if you then ask individuals, and we ask this at baseline before the risk is being communicated, being estimated, and then at Q3, so 1 year after risk communication, if they would be willing to be screened more frequently, if they were found to be higher than average or high risk. And across the board, everybody was like, yep, definitely. 90% of individuals, no matter where their estimated risk ended up being, said, yeah, I would be willing to be screened more if I was high risk. Now, if we ask the opposite and say, if their risk was found to be lower than average, would they be willing to have their mammogram less often than they usually have? Then the results were much more mixed, with only about 20% saying, yeah, I'd be okay with that. So really, this sort of goes back to the idea of whether this approach could be cost effective, because really to be cost effective, you have to be screening some people less and other people more to have things balance out. The same is true if we say that this is an approach can balance benefits and harms, right? That this requires this type of redistribution of screening resources. And we actually saw pretty much the exact same results when we did a survey that included Ontario, Quebec, and also Alberta and British Columbia. Same types of things. And this is not in other jurisdictions in the United States and in Europe, they found the same thing, where people are good with more, but they don't want anything taken away. Now, also part of this work, we have engaged with healthcare professionals at various levels to sort of understand their perceptions of this type of approach. And really, there's a huge knowledge gap that would need to be addressed if this was to be implemented. And this is less of a gap when you look within an academic setting. But of course, we're talking about bringing this out of the high-risk clinic. This is going to be out in the community setting, not at Sunnybrook, not just at Sunnybrook, where everybody is, very familiar with this type of thing. So most of these healthcare professionals said they would require more training. This should be included in the education of both nurses and in the medical curriculum. I'll note that in Quebec, the role of the nurse practitioner is very big in primary care. And so when we think about implementation in Quebec, the nurse practitioners would likely play an extended role. But overall, most individuals said that they didn't currently have enough information about this type of approach to really move ahead with it now. And I think that that's not really particularly surprising. Okay, so I'm just going to go over a few sort of the key points that come up from this related to some of the challenges you can see in implementation that we sort of identified. There's definitely a benefit in working within existing programs. A lot of the mechanisms of sharing information are already in place within the OBSP. But this would have to be further augmented to allow the expansion of this approach for risk-stratified screening. It seems that by taking a self-referral type approach rather than a healthcare provider referral, an invitation letter approach would likely be more feasible within the context of this. And to facilitate data collection and risk estimation, it would be important to have the risk assessment tools or the data that's collected already be in the format that is needed to go into the risk assessment tool. So as much of this can be automated as possible. And I think that that's where a lot of efforts right now are going. And then also just improving comfort and acceptability about receiving this information, receiving and communicating this information for people, outside of genetic counselors, right? Because we don't have enough genetic counselors to take on this work at a population level. So there are also needs to further customize the tools for the Canadian population. Now, a lot of this has been done for the risk factors. We did this as part of Perspective and found that the information that is currently informing the Bodicea model applies very well to the Canadian population. Where we have challenges is related to the polygenic risk score, which was developed pretty much exclusively in individuals of European ancestry. And so there are issues related to portability across ancestries, especially in, I think, a very heterogeneous population like Canada, where there's a lot of admixture. And we have done there's been a lot, this is a huge area where a lot of people are doing a lot of validation in different populations and finding that you can use different weights to sort of make the polygenic risk score more applicable to different populations. But before we can really bring the PRS into the risk estimation, we need more validation here. I think, yeah, I'll stop there for that. And then in terms of really sort of implementing this approach, we are still following up these participants in order to see whether it works, right? So is it identifying those individuals at the highest risk? Is it identifying those individuals who go on to develop breast cancer? Are they following the screening recommendations? Is it motivating them? Is it not? Is it creating more anxiety than action? We need to enhance the acceptance and support and knowledge of the healthcare providers that can support the participants. At least, like, we can't know for sure, but it seems that having the primary care provider there to support them in Quebec reduce some of that anxiety. And there are also the need to develop policies related to social ethical legal challenges. So there is, laws related to genetic non-discrimination, but what about risk prediction? That's not the same as a high penetrant variant that is associated with a very high risk. So all of this would need to be considered when moving through implementation. And we do have a very large social ethical legal group within the Perspective study that is addressing many of these challenges. And then finally, looking at the cost effectiveness. And Nicole Mittman is doing a lot of this work, trying to model different scenarios of screening moving forward and trying to see how it would play out, especially if we don't have people who are willing to be screened less, right? So that acceptability and sort of buying in to the risk stratified approach is needed by healthcare providers too, because there are a lot of healthcare providers who are mixed on whether it would be individuals should be screened less if they're at lower risk. So a lot of the work that we're doing now is trying to find ways to sort of streamline this approach. So what is the minimum family history data needed? What is the most parsimonious group of variables that we can use to estimate risk? Because of course, we're looking to put people into a category, right? So this is not the same as in the high risk category, in the high risk clinic, where it's a little bit different. If we're talking about the population, we're looking, to just put people into groups that then informs their screening. And so we want to be able to do this as accurately as we can, but also as efficiently as we can. And so another thing we're doing is looking at what happens if you use the data that we already collect as part of the OBSP. So on the little sheet that every woman completes when they come in for their mammogram about hormonal exposures and menopausal status and parity, and there's family history on there a little bit, trying to see how well we can do with just that information in terms of estimating their risk. And of course, the issue of portability and making sure that we are not increasing disparities, health disparities, by making information complicated and inaccessible and unavailable to subgroups of the population who are typically underserved. We don't want to be widening disparities. We want to, the whole point of this is really an equity-based approach, right? This is risk-stratified screening is equity-based. It's giving more screening to the people who need it and less screening to the people who don't. So we need to make sure that that's applied evenly across the population. So again, we're looking to sort of streamline that recruitment process, validate the tool, really what do screening outcomes, what do cancer outcomes look like in the prospective cohort as we follow them up moving forward, and looking to find different ways of actually implementing the framework within the social legal environment and the different healthcare organizations from province to province. So within patients, we need to consider the uptake and acceptability and look at things like screening outcomes and cancer outcomes. The providers, again, acceptability and education, but also care pathways and SOPs that make this, that are integrated within the existing programs to make uptake, to facilitate uptake. And then of course, within the health systems, and it really is multiple, right? There is not just one. Even in Ontario, I think we would have to consider resources and costs within different jurisdictions to be able to appropriately roll something like this out. So this is a huge project team that is involved in this. It's a really amazing group to work with. And there's a huge Ontario group, including Kathleen Bell and Andrea Eisen, who it really worked with us very closely on how to get this this project working. So I'll stop there and take any questions. Thank you.
I have a question.
Sure.
Somebody else does. So Jennifer, I assume that there are other parts of the world that are a little ahead of us in doing this kind of thing. Do you have any outcomes from your studies? Preliminary outcomes?
So Ellen, just for those of you who are online, just asked about results from other studies and where they are at. And surprisingly, they're not really as far ahead. A lot of people got slowed by the pandemic. The Wisdom trial in the United States, it's a clinical trial, and they had a hard time recruiting for sure. I'm not aware of results from their study yet, and there's quite a lot of variability. So my PEBS, for example, is using a single cut point for what's being called high risk and not an age-based cut point, which I know we've talked a lot about within sort of rethinking the current high risk OBSP guidelines in terms of age-specific categories, but we're not actually far behind from anybody. I think a lot is going to come out over the next year or so. Yeah. Anne.
So with this group of women then, is the intention that you do blood tests for everybody on entry into the screening program? And if so, how much did it cost to do the SNP screen?
So Anne Martel just asked about whether we would do blood tests on everybody and how much it costs for the SNPs per screen. So the SNP costs for this, it went up recently. It's a little hard to say because what the cost would be now, because the reagents were scarce during COVID. And so we had quite a lot of problems, but it's probably a couple $100. And I believe that Tracy Stockley, who is the one that did this at UHN, she has already incorporated the polygenic risk score into the multi-gene panel in anticipation, so that it's really already can be seamlessly integrated into that test. Now, in terms of how this is rolled out at a population level, I think that's really challenging. You can see from those curves and the risk, the way how much the PRS does to stratify. It's not enough on its own. There's been work to look at that. Can you just use the PRS? Because otherwise we could just get a blood test from everybody when they turn 30 and it, you know, that would be a great way to sort of automate a
Please, your
process.
attention, please. Code blue, C Charlie Wing, 3rd floor, room 53, bed 1. Your attention, please, your attention, please. Code blue, C Charlie Wing, 3rd floor, room 53, bed 1.
So I think, you know, in terms of actually doing this, I mean, right now risk is being estimated without the PRS, right? That's happening. And it's often also done without the mammogram because you have individuals who get referred to the clinic. They're in their 30s or their 40s. They haven't had a mammogram yet. And so risk is done with what information is available. Now, the benefit of a polygenic risk score, I think, is that it doesn't change, right? You do it once. It's not going to change over time. Maybe the actual score that we use gets refined, but someone's germline genetics don't change. So really, you only have to do that test once. So it's different from something like mammogram, where you have to do it over time and you have to update family history and you have to parity and all of these things, these variables change. But the benefit of a PRS is that it doesn't. And so I kind of like some of those more just agnostic type things that we can try to pull in and do. And I think there's a role for AI and image analysis and, you know, getting as much information from the stuff we have already, like getting more information from that. So more information from the blood sample, even when we're assessing for the polygenic risk score, you can look for other things too. And then the image, and just try to automate as much as we can. But we're a long way away from that for sure. But
Escape and stop sharing, by the way.
oh,